everyone. Thank you for joining us for AO Trauma North America's Orthopedic Trauma Journal Club series. Tonight, we will be discussing non-unions.
Today, we're welcoming Dr. Will Oliver out of Edinburgh, and we're going to be discussing his recently published paper in the Journal of Orthopedic Trauma, Open Reduction and Internal Fixation for Humeral Shaft Non-Union. Bone grafting is not routinely required and avoids donor site morbidity. Welcome, Will.
Thank you very much, and thanks very much for the invitation.
Yeah, my pleasure. I was hoping you could start by giving us just a quick summary of your study and what the major findings were.
Absolutely. So, this was a retrospective study looking at the outcomes of patients managed in our center over a 10-year period who developed non-union after a non-operatively managed humeral shaft fracture. So it was a retrospective study. We basically looked back over all patients who fitted those criteria, and we came out with a cohort of 86 patients that we were able to follow up. And I guess the three major findings that we identified from the study were, first, that humeral shaft non-union surgery in our cohort of patients was associated with a high rate of subsequent union. So the union rate after fixation in our study was 93% overall. And within that, for patients in the study who were managed without autologous bone grafting, which was the substantial majority of our study cohort, the union rate was 95%. Regardless of the type of non-union that the patients had developed. So the union rate after an atrophic non-union was 94%, and the union rate after a hypertrophic non-union was 96%. So that kind of demonstrated to us anyway that plating without bone grafting was effective in generating union in this group of patients. The second main finding, I think, that we wanted to highlight was the relatively low rate of complications. Like all non-union papers, I think we accepted that we were expecting a slightly higher rate of complications compared to some primary humeral shaft fracture fixation. We identified a 6% overall rate of transient radial nerve palsy. And the rates of things like superficial infection, 7%, deep infection, 2%, were very much in keeping with the numbers that you find in the established literature. But one interesting aspect was looking at the small number of patients, only 8 in our study, who underwent iliac crest bone graft augmentation along with their fixation. So of those 8 patients, 3 of them developed a donor site complication. So that's a 38% overall rate. There's one patient with a wound hematoma, which required dressings and additional outpatient follow-up, and 2 patients developed transient lateral femoral cutaneous dysesthesia, which was, sorry, it wasn't transient, it was persistent at the time of final follow-up. So no major complications from the donor site requiring further surgery, but nonetheless not a completely benign intervention in our center. And add that to the sort of context where potentially we have iliac crest bone grafting being unnecessary in most patients, and also exposing patients to those potential, albeit relatively minor, donor site complications. The third area, the sort of final thing to highlight, I think, was the patient-reported outcomes, which we also obtained from those patients who are living and cognitively intact and had valid contact details. And of those, we found that there was a definite trend towards inferior function, and according to the quick dash and the physical component summary of the SF-12, as well as higher than expected rates of things like pain and dissatisfaction with treatment outcome. And that was across the board, regardless of whether bone grafting was used or not. And that, I think, kind of hints at maybe there is a long-term legacy to non-union, that these patients perhaps weren't as happy and as functionally adequate as we had hoped they would have been, given the longer-term nature of the follow-up.
You think that would have been different if you'd had a cohort that included people who'd healed primarily?
Well, I think that's a great question, and actually we here have run a study looking specifically at that to see whether it's the fact that you have a non-union that is what impairs your outcome. So we actually have a paper that's in press with the JOT at the moment comparing those who united primarily with those who united after non-union surgery. We found that the non-union actually does seem to be an independent risk factor for a poorer outcome.
Yeah. Why did you guys do this study now? Was there some pre-existing literature that prompted a change in your treatment protocols, or what drove this?
I think if you look at the literature around humeral shaft non-union fixation, a lot of it involves the cohorts which were managed with plating with additional bone grafting, usually autologous iliac crest bone grafting. There's only a handful of papers which document outcomes of surgeries without adjunctive bone grafting, and there's a great review by Peters et al. Out of the Netherlands, who published their systematic review in the journal Injury in 2015, and they found just 2 studies involving a total of 19 patients with outcomes documented for humeral shaft non-union fixation without bone grafting associated with it. So there's potentially a slight gap in our understanding, and it didn't really fit with our own practice in Edinburgh. As I say, Professor Keating, among others, has long been an advocate of simple plate fixation done well, and his experience, which is obviously extensive, didn't seem to match up with the prevailing wisdom in the literature. Was that bone grafting was a necessary adjunct for these patients. So that, I think, was the motivation to see, okay, what are our outcomes? How well do we do? Is there a difference? Should we be doing grafting more often?
And that was regardless. I mean, these results that you've had are regardless of whether or not somebody was what would traditionally be considered a hypertrophic or an atrophic non-union, which I think was maybe a little bit eye-opening in this study as well.
Yeah, well, I think that's it. If you look, digging deeper into the literature, the evidence for plate fixation without bone grafting in atrophic non-unions is vanishingly small. I think there are about 6 or 7 or 8 patients or something in the literature, and we had 40 or 50 in our series. It's one of those where I think the reality is, we know from several very useful basic science studies that even atrophic non-unions are usually sufficiently vascular and retain the key bone signaling components, like bone morphogenic proteins and things, in order to unite if the mechanical environment is corrected appropriately. And I think this paper kind of very much echoes with another paper which I know is up for discussion in this journal club from the group out of Nottingham, where they looked at that unified theory of bone healing and non-union. And although, as we all know, non-unions can be biological or mechanical, I think in clinical practice, the reality is the vast majority of humeral shaft non-unions are probably mechanical, even though they may be atrophic or oligotrophic. And if you correct the mechanical environment predominantly with plate fixation, interfragmentary compression, and stability, then the majority of them do go on to unite without the need for anything extra.
Yeah. So after all of this, how do you guys decide who needs bone graft?
I think the indications for bone graft are unclear. In no way are we trying to suggest that there is no role for bone graft. I think bone graft is absolutely critical in certain situations, especially in failed primary fixation, for example, or recalcitrant non-union. But I think all that this study suggests is that it may not be needed quite as often as some authors have previously felt, especially in the setting of failed non-operative management.
Do you think that we can apply these findings to any other non-union sites?
Well, it's interesting you say that, because I think one other thing about the existing literature is that a lot of literature suggests that you don't need bone graft for other long bone non-unions. So Prof. Keating, again, senior author on this paper, was a senior author on a review of the risk factors and outcomes of long bone non-union in the clavicle, humerus, the forearm, the femur, and the tibia. Actually, the humerus is a bit of was out on its own in terms of the predominant prevailing wind, if you like, in the literature being one that suggests bone grafting is the gold standard along with plate fixation. So actually, I think this study potentially is just balancing that argument a little bit, which in the past has maybe been a little bit too heavily weighted in the favor of bone grafting. And I think the principles of this, as we've alluded to from the Nottingham paper that you're going to discuss, are already being applied very readily elsewhere. The reality is it's probably less applicable to lower limb fractures, in that a lot of those are managed operatively in the first instance. So having a non-operatively managed femoral or tibial fracture is relatively unusual in sort of both sides of the pond, I think. Mm-hmm. So that may be a factor to weigh in, but certainly in upper limb fractures, I think a non-union following non-operative management, plate fixation alone is normally and has been demonstrated to be very effective.
Anything that you would like to add as a takeaway point from all of this?
Maybe one thing that comes out of this is to highlight that however you do it, I think trying to identify and get to the 20% or so of patients who are at risk of non-union after non-operative management is probably the key to improving overall outcomes, because it's clear that the majority of patients do extremely well with functional brace, and that will continue, I suspect, to be the default management strategy, and quite rightly so. I think there's probably is something more to be done in terms of trying to identify and get to these guys before they progress to an established non-union, because, as I mentioned, that may well confer longer-term functional advantages to them.
Great. Okay. Thanks very much for joining us today.